So it is June, and there's
Oh, wait.
right. Get on. Hey, Rob.
Hey, how's it going?
Hey, thanks for joining today. We may have Claudio join us here shortly. I don't know. It's noon, so we're going to go ahead and start. Okay, I want to see if everyone could just quickly introduce himself with just your title and where you are located. Armando, can we start with you?
Sure, Armando Samaniego, Chief Medical Officer, Stat Med Urgent Care in Bay Area. We have 4 sites.
Nathan?
Yeah, Dr. Nathan Kiskill. I'm president, co-founder of MARC Urgent Care in Southern California. We got 10 locations, Southern Orange County, San Diego, and Riverside.
And Tiffany?
Hi, I'm Tiffany Reguera. I'm a nurse practitioner, and I own Anderson Walk-In Medical Clinics, and we're in far Northern California, and we have 3 sites.
And Rob?
So Rob Mahan, CEO for Exeter Urgent Care. We're located primarily in LA County, a little bit in Southern Ventura County. We have 20 locations and virtual care.
Okay, great. So I want to start off the questions today with, once again, sort of update on sort of vaccine status. I know, I think 3 or 4 of us are vaccinating. Armando, I want to start with you. What's your vaccine availability? How easy has it been to get the vaccine?
We straddle 2 counties, and we've been vaccinated in Alameda County for 2 months now, and which has been going well there. We've been getting the vaccine we need. We just started in Contra Costa and just literally got it last week, and we're ramping up now with staffing and we have Moderna, and I think we have access to Pfizer, although we're just doing Moderna now. So we're in the process of ramping up our vaccination process. So we're fortunate and happy to be part of the solution with the vaccinations.
Okay, and I think from earlier, you said that you're still waiting on your Blue Shield contract, right? Just like a lot of us are.
Yes.
Okay, right. Nathan, you guys are vaccinating, correct?
Yes, we are. Same thing, it just kind of depends on the county. San Diego, Riverside County, we have been. Orange County, not so much. We did get the J&J vaccine. So we've had the Moderna and the J&J. We have not signed a TPA agreement yet with Blue Shield. Still waiting to do that, hopefully.
Okay. Claudio?
Claudio's on mute.
My bad. How you guys doing? We are not vaccinating yet. We only have a location in Orange County. We have not been able to obtain vaccines yet.
Okay. And Tiffany, I know you're not vaccinating at your facilities, right? Right. Okay. And
Right.
Rob?
So I think we're going to start getting into the vaccine business as of, somewhere around maybe the 20th of April. But, and we did get a response back from Blue Shield on the TPA. So I think we've sort of gotten some good headway in that area, but I still chuckle a little bit just because it feels like there's still a lot of unanswered questions that we're still trying to get resolved right now. But it seems like that's the direction we're heading.
Okay, great. I'll start up again. Armando, have you started using My Turn?
No, we are still, that's still part of the TPA process, I think, for us. We're using PrepMod. Our county is still using PrepMod for both counties. So I know the state, the county are using it as the patient-facing side, but we're not using it on the provider side. We're still using PrepMod. And the county assured me that I will at least have a couple of weeks lead time before it goes away. So
our county basically said at the 1st of April, they no longer had control over the supply of vaccines and would not be able to give it to us anymore because it now had to come through the Blue Shield route. Is your county still actually giving you?
Yes. And it seems like I heard this similar scenario, but when I asked our county, they're still controlling it, both counties. And because I don't think they've turned over completely everything to Blue Shield or the CAlUCA system. they're still controlling this process. And a lot of it's through the equity situation.
Okay. And anybody had any serious reactions? Anything adverse? We haven't had any. We've given out a couple thousand vaccines, maybe more. We haven't had anything wrong. Okay.
Vasovagal responses on a bunch of young guys.
That we've had a few, but really minor. And this might be a moot point now. Our county has, as of yesterday morning, told us we could vaccinate anybody over, we have Moderna, so anybody over 18 we wanted to, irregardless of health status or any other eligibility requirements. Is that what's going on with you, Armando?
Again, we straddle two counties. The Contra Costa County opened up to 16 and older as of last week. I want to say maybe 10 days ago. And so anyone who's over 16, it qualifies. Alameda County is still over 65, and then and I think they're going down to 50 this week. And so it's a little, these two counties are right next to each other, so it's a little confusing for the patients. So.
Nathan, how about you? What are you still following a tier system?
Yes, we are with the counties that were in San Diego, but they have, I believe, next week it'll change to it'll change again to I think almost, well, we don't have the Pfizer, so we're not doing 16 and up, so still 18. But we've still been following the tier system unless it's an open vial that there's an extra dose or two that you just give to kind of whoever's there.
Right.
But we're kind of at the last of it. I think it's what the county has given us to finish second doses, because I understand we're going to be moving to the MyTier system, just like Armando. We haven't been using the MyTurn because that's tied to the TPA agreement, with my understanding, and so until you do that,
yep.
So I guess what I'm saying is we're still kind of following the old school tier system. Gotcha.
How are your counties? We also straddle two counties, and that's been really, really interesting. How is it working with you down there with the two counties? Are they on the same track, or is it just like a different world in each county?
Between San Diego and Orange County, it's like a different world. We're also in Riverside County. Recently, the last couple of weeks, actually, Riverside County's probably been the best one as far as getting the vaccine, giving us the most vaccine. And they've been giving us the J&J vaccine, which a lot of people like because it's just that single dose. But no, it's a little funny or strange, but it's really different, and dealing with each county has been almost a world of difference. They're really different.
Yep.
How many doses of the Janssen vaccine did you get?
Honestly, I don't know. I think it was quite a few hundred, or whatever it comes in, a case 900 or something like that.
And it's stored the same way as Moderna, right? It can store up to as long as you want. And
yeah. Rob, are you guys doing much testing down there?
Yeah, we still are. It certainly obviously dropped from what it was during the kind of December, January time periods, but we're still doing testing at this point. But it's probably, I don't know, maybe a third of what it was in terms of the volumes back in sort of December, January time period.
Okay. Claudio, you guys are testing as well, I know, right?
You're on mute, Claudio.
Sorry, it's twice. 2 strikes you're out. 3 strikes you're out. We are still continuing all the same testing operations, but the volume is, we're probably at 25% of what we were, say, in January. That definitely was a peak. We're about maybe 75% of where we were last summer before the big winter surge. So definitely a lot quieter all around.
Okay. Nathan?
Let me unmute myself, but no, same boat as Claudio. Basically, it's definitely died down. We are still testing. I think one thing we're maybe doing is we're really trying to get people back into the clinic. So I think we're doing a little bit more testing just to get people, back in the clinic to be seen. But as far as just, the drive-through parking lot testing, I mean, that's definitely tailored off quite a bit.
Okay. Are you still doing all your testing outside?
It depends on our location, but I think maybe all of our locations except one we've been doing outside. So yeah, kind of like Armando said, being in Southern Orange County and San Diego, I guess we have that luxury with the weather to do it outside.
Armando, what about your testing? Is it about the same?
I think everyone's probably down from the peak of January, the holidays, but we've started to see a slight uptick. We went to an online system for testing, so that's helped. But we're starting to see more testing in the sports people that are traveling and going to sports. So we're starting to see that, and going back to school. So we're starting to see a slight uptick, but we're probably down at least 50% compared to the average.
Have any of you been approached by any universities or schools or large employers that do really large scale testing for them?
We have.
What is Claudia, tell me about your experience. Who was it? I mean, is this the city of Irvine?
Well, we've been working with the city of Irvine since last July. We're the clinical partner for that over at the Great Park. And as I mentioned before, that went anywhere from 100 tests a day to, I think the peak in January was like 600 tests per day for about a 2 or 3 week period. But specifically with corporate accounts, what we did is we were actually proactive. We called, we have good relationships with several restaurants in the area. And we started with them when they were here in Orange County. They kind of opened and then they closed and they opened again, and it was outdoors. They've been kind of back and forth. So we approached them and set up. Actually, we have a crew we have several crews that go out on site and test people at locations. It started with restaurants. It's spread to grocery stores. And then also some large manufacturing. We go all the way up to LA County. We've tested as many as 600 people in one manufacturing plant.
Wow.
Over the course of 2 days up in LA. And so that's kept one of our divisions pretty busy doing that. That has tapered off now as well. But the thinking with that is that even as we reopen and people go back to work, employers will still be interested in having their folks tested. As long as we can, depending on reimbursement and the COVID fund, the CARES Act, and all those other variables. But right now, we're still continuing that.
Claudia, can I ask you a question? You said 25%. Are you down, including your offsite testing, about 25%, or including that? Or?
No, just the drive-through,
Okay.
testing, and the drive-up testing here at the clinic is is down significantly. But the corporate, it's dipped a little bit. There was that frenzy, January, February, even the very beginning of March, and that has gone down a little bit, but it's still fairly consistent.
Okay, that's good.
Can I ask, how are you maintaining those records? We've been doing some football teams and things. And so are you building charts, or are those records solely owned by the corporation? What level of record keeping are you doing for the mass testing?
Yeah, so we're not technically doing it for the corporation like you would with a workers' comp or an employee paid service or something like that. It's more of a convenience. It's an on-site testing, but we treat patients as individual patients. They're asked to register individually through our online app. And then we do either a combination of remote televisits, and then a tech goes out there on that day and swabs everybody. And they've already been charted and their insurance information uploaded, and then they just get the swab. Or we'll do an on-site spontaneous observed swabbing with a provider online. So it's a combination of the two of those things. But we treat the patients and the records as individual patients, if that answers your question.
Yes. Thank you.
We're actually doing a visit.
Yeah,
we are doing a visit.
Oh, wow. Okay. That's great.
Claudia, what test are you using when you go out on site?
It's gosh, don't quote me on it. It's just it's a regular PCR through a lab here. It's a local lab in Costa Mesa called Pangea. So I don't know. It's a molecular PCR.
So you're collecting the swabs and then you send them in, they're all good. Okay, got it.
Yes.
Are you doing any rapid testing on site?
No.
Okay.
No, we're only doing rapids here at the clinic.
Okay.
Is that requested, but they want a PCR, or is that what you offer?
Probably a combination of the two. I think early on it was very consistent. Just as you know, there's too many moving parts with the rapids to do. You can't do 600 rapids. You can collect 600 specimens, but we can't send them to the labs. It's a send out lab for us. The rapids here on site we can do because we have enough machines to do them, but we can't do anything large scale with the rapids. We're using the Sophia 2, the Sophia 1 and 2.
Right. Has anybody used the Binax cards for testing? It's an antigen test. Have you guys seen those? They were just.
Yeah, that's what we use.
Do you?
Mm-hmm. And I like them, but that's we take them on site, like to the football teams and things, and it's nice because you can do them very quickly.
Yeah, so we're contemplating doing that for a local university, just because of the ease of the use of it. It is an antigen test, and it comes with all the the qualifications and maybe lack of specificity for that, but it is something that's can be used for mass testing. So I was just wondering if anybody else has been using that.
Can I ask a general question to the whole group? And that's the Binax card is also one of the cards that's being approved for over the counter. And my question is how, what's the documentation charting on that with the state? Because we're supposed to, report that to the, all of our testing to the state. Does anyone have any experience on that? Because I assume everyone's reporting to the state because all your negatives as well as your positives.
Yeah, Tiffany, how are you guys? Are you guys reporting?
Yeah, we're doing the same thing as if it was a PCR. So we have to do a full, morbidity and mortality report for each of them. So
yeah.
And our county, if they're symptomatic and the Binax now is negative, they still want us to report it as a positive.
Oh, really?
Mm-hmm.
Okay. Okay. The next topic I wanted to hit today was staff vaccinations and the idea of the COVID vaccines for your staff. And there's been some discussion about because of the seriousness of the pandemic and its effects on patients and staff and so forth, that some employers are thinking about requiring staff to be vaccinated. California has, of course, some exceptions to that rule. There's a medical exception, I think a religious exception to vaccinations, but beyond that, if the staff didn't fall into one of those, there's been some talk about just basically requiring COVID vaccine for staff. Have anybody considered that? Armando, has your group?
That's a great question, and I would say we have about 60 staff members, 60 to 70, depending on who we count, contractors or not. And I think there's only like 2 people that elected not to, and I'm going to do a circle search back on our organization because I think we are vulnerable for, particularly if those patients are on the front line or staff members because of the potential risk. But this is something, I have 2 sons that are in the Navy, and for vaccinations, because this is something we should probably look into, because it is an EUA approved and not FDA approved, they cannot mandate that the service members receive it. But what they say, if you want leave, if you want to go on leave, you get the vaccine. But apparently, from their perspective, because it's not FDA approved, we may have some challenges about that. But you may be able just to move those people off the front lines and put them into the back office situation. And I think that's what we're thinking about doing, is evaluating those who are, if you're on the front line, it's a high risk to them and to us. then we may need to move them to a different scenario. But I don't know if we can officially mandate it for an EUA approved medication. And that's just following the lead from the military. So.
Rob, what's your feelings on this? Have your group considered this?
Yeah, so I think we're at the beginning phases right now of this, trying to understand it. And I think to what Armando was just speaking to, trying to sort of figure out what is, I mean, you got to kind of navigate what's safe on one side, but of course, California has its own set of extensive rules and that you have to sort of take into account. I think the sort of potential solution that we may end up landing on is just sort of following what we did with flu shots in the past, which is not making it requirement, but saying if you choose not to get a flu shot, then you're going to be required to wear a mask. I think we're still debating whether or not you would also have to continue to wear protective eyewear, but that potentially being a part of it as well. And, effectively say, if you're not going to wear, if you're not going to take the vaccine, then you're going to, you have to sort of have additional protection that you'll be required to wear, which is what we've done historically with flu in previous years as well.
Yeah,
Rob, everybody's wearing masks now, even at work. What's
yeah. Well, my point is that as we move towards this, towards this in the future state, I'm assuming masks aren't going to be required for everyone. And so, once it's no longer required, saying you would have to continue to wear one if you chose not to be vaccinated.
Yeah,
so I'm thinking more of future state as opposed to kind of today.
Yeah, I've been looking at that as well, Rob, down the road, as we get sort of more toward normal, the dilemma that sort of that develops, of course, is the flu was fairly seasonal, and you could say you had to wear a mask from October until March. With COVID, what is it? Just you wear a mask forever? I'm not sure how you handle that. Anyway, anybody else come up with Nathan? Have you thought about this?
I have, and I don't have a perfect answer either. I'm probably really in the same boat as Armando. It's just very highly encouraged to our staff. We did offer a $100 gift card for everybody who got vaccinated, that's staff, and so we did have some pretty good, compliance as far as that's concerned. But it can't be mandated, and and I guess we just remind our staff that all of those that wanted to be vaccinated are vaccinated, and if you chose not to, then you chose not to. But everyone's still wearing a mask, and everyone's going about work the way that they are. But how long that's going to last, or I like personally, I think we may be wearing a mask for some time now. Maybe even a year from now. So,
Claudio?
Yeah, I was going to agree with Armando that I did look into the subject a little bit, and right now it seems that it can't be mandated just because of the fact that it's not FDA approved yet, which is different from the situation with the flu. I think I've only had maybe one person, and they're still just bumbling with the app. I think they want to get vaccinated. So I think we're looking at 100%. I have one person that's about to go out on maternity leave, so she opted not to for totally different circumstances.
Right.
But so we have a very, very high acceptance rate with it.
Tiffany, what's your experience with your group, your clinic?
I've had the exact opposite experience. I think I have 30 employees, and I think I was almost the only one. Sorry, guys. The only one that got vaccinated. Sorry, my children are fighting in the background. They're going to a skate park. And my main physician actually coaches the local football team, and he lived to regret that decision because he got it and his son got it, and it shut down the whole high school football team basically because he didn't get vaccinated. So I love the $100 gift card idea. That's phenomenal. I'm going to do that tomorrow.
So, all right, thanks, Tiffany. So then I have another question for everyone on the panel. And this is, I guess, if we assume that this vaccine or the Ssris vaccine will get FDA approval, and they will be, just like the, influenza vaccine, and sometime in the future, can you or should you, or do you think we should require all incoming new employees to be vaccinated as part of a, a condition of employment?
Yes. This is Armando. I think we're going to head there. Not only that, we're probably going to be checking antibodies, just like we do with hepatitis B and and everything else. So I think it's going to go there because it's too high of a risk, so that's my thought.
Rob, what's your thought on that?
Yeah, again, we're kind of in the earlier phases of this. I like Armando's idea. I just, again, from our perspective, I don't know if we've reached the conclusion that we can require as a condition of employment. So I think great idea. We just got to make sure it's legal. Is kind of the constraint we're sort of exploring on our side right now. But so I think that's going to be the issue one way or the other related to it, and we'll find out. But again, kind of not done yet.
Nathan?
Yeah, I agree with Armando and Rob, both in the sense with Rob that I don't think it's happening, in the short term. But I do feel that and I don't know what time that's going to be, that at some point we probably will get to, once we can mandate it or, prove certain things, that, we probably will be checking their titers just like we're checking, someone's, MMR titers, when they, get a job in the hospital or, that sort of thing. And so I think it probably will go there, but, like right now, if we were hiring someone for a front desk position tomorrow, it would just be highly encouraged. But I don't think, whether they get hired or not would be, we'd be able to, hinge that on whether they're vaccinated or not.
And Claudio, have you talked about this internally in your group?
We haven't, but I do support the idea, the notion that it would be required. I know firsthand from, my wife is an RN in a local hospital here, and every year it's the whole, I hear the scoop on the flu shots. It's like, if you don't get the flu thing, you wear the mask all year long, that sort of thing. So I think that we would probably adopt a similar model, something like that. We would probably get some kind of guidance once, it's approved and it's enforceable, then we probably would go along with something like that, as long as it's feasible.
Tiffany, what are your thoughts? Have you contemplated this?
Yeah, I have, and I don't really know how I feel about it yet. I know this was the first year at the VA for the flu shots that they actually terminated people if they were not going to get a flu shot. So I had never seen them do that before, but they fully it wasn't the option for the mask or anything. So they took it really serious for the flu shots this year. So I don't know if this is just the trend of the future, that we're going to be going towards mandated immunizations.
Wow, that's
yeah.
I hadn't heard that yet.
Yeah.
Anybody have any other thoughts on staff vaccinations? So if not, I want to go to our next topic, which is the E&M coding changes for 2021. As everyone is aware, the E&M codes have sort of fundamentally changed, at least in the way they're calculated. I mean, we got rid of the 99201, which was apparently never used anyway, so it wasn't really a big deal. But as far as in thinking about the E&M coding revisions that just came out, what changes have if any of you made into how visits are coded because of the changes? And just broadly, has anybody really made a move on this yet? I know a lot of people actually haven't. Armando, has your group done anything?
The thing is that we've seen a lot more down codes compared to what we had before, because the system we can't get as many 15s. One thing we've been doing more consistently is adding more differential diagnosis in our diagnosis, where before we didn't. And I think that helps with the acuity, and also, I feel more like an internal medicine person who does that all the time. But in the ER world, we're happy to get one decent diagnosis. So we're putting in a lot more differential diagnosis.
Nathan, has your group seen any kind of change or made any moves on this, like a move in this direction?
We did, in January, this first couple of weeks of January, we, because our EMR lets the providers know when they're signing off, what their E&M code would be, or suggested E&M code. And So we did have a lot of providers saying, hey, I'm kind of charting the same, and sometimes I'm not getting that higher level of acuity. And so we kind of jumped on it, and we really spent some time, training the providers. I think as far as our practice, the way we practiced or took care of patients didn't change. It was more kind of what Armando said, making sure that we're entering that differential diagnosis, or just our medical, decision making, typing out, hey, why are you thinking this? Or, why are you doing this? And spending more time on that, which likely you're doing anyways during these patient encounters, and don't worry so much about, making sure that you're filling out their past family, history, or, some really long review system when it's not, pertinent. And so I think the Urgent Care Association was pretty good at coming out with some couple different webinars that were available, to watch, and then some other things, kind of like little. I think they came out from the AMA, but the Urgent Care Association had them as well, that you can print out and kind of have on the provider desk, to just remind them, how to get, the proper code depending on, which, how many, what their diagnosis is and their medical decision making, and, all sorts. So yes, we did have to we did see a little dip initially, and hopefully we've fixed that. But we did really do spend some time with the providers trying to get them to chart correctly what they're already doing, to make sure that they get counted for their hard work.
Do you think your providers are using mostly the medical decision making or the length of time?
The medical decision making. So, as you know, urgent care, it's, you're trying to get those patients in and out in 15 minutes. So I'd really encourage them to use the medical decision making. If you're spending an hour with a patient in the urgent care, it's
probably wrong.
That's not, as you guys, I'm sure, all can attest, that's not good.
Yeah. Claudio, what's your group approach to this?
We're still, I was a little bit slow on the uptake on this one. So we're still kind of in the education phase. We are reviewing, as Nathan said, some of these webinars, and luckily they were recorded and we can go back and share them amongst the providers. So we're still in the process of just getting up to speed with this.
Okay. Tiffany?
Yeah, we're about the same. We're, trying to get the providers to chart or code for symptoms and that kind of thing to try to push the numbers up. We're using the time more for work comp cases, especially if we're inheriting work comp cases or work comp cases that have a lot of records reviews, that there's not maybe a lot of charting, but you have 200 pages of a case that's from 1986. Then we're saying, review 200 pages, estimated time. So we're doing some time documentation on more work comp than anything else.
Okay. And Rob, I know you've been thinking about this since January. Where are you as far as educating your providers, and what are you doing?
Yeah, so we did a fair bit of analysis related to this, and I'd say long term, I think that we're going to be able to help kind of offset a lot of it. And so we have done a lot of research. We actually also kind of got some legal analysis from, kind of a physician practice or from a legal practice that focuses more on coding areas on some of the more nuanced issues associated with it. And we're in the process of kind of rolling out the education related to it right now. And I think we'll be able to offset maybe 3/4 of what the decrease was, but I don't think we'll be able to fully offset it, at least, inside our, with our urgent care system. So I think that some of it is a permanent sort of push down, and it was by design. So, now CMS did a lot of things to try and offset that, including increasing CMS rates pretty substantially for returning patients. So from their perspective, there's been things that have, they've put in place to help to offset it, but most people are probably dealing with contracts with private payers that are proprietary fee schedules and aren't subject to any changes from CMS. And so it doesn't necessarily mean that those rate changes are going to sort of flow through. And if they do, it'll probably take, years to kind of get that to sort of fully reflect in people's contracts. So I think there's a lot that can be done, and a lot of that's just education to kind of change how things are documented, but I don't think we're going to be able to completely offset that. So I think there is going to be some kind of permanent E&M decrease on average across urgent care is just my guess.
Does your EMR suggest a code for your providers to use for a note?
It did historically, but I think because there's so much of this is now more about the medical decision making, they sort of pretend it does, but it doesn't really, where you can select for the 3 columns of, that are in the billing guidelines grid. You can sort of select your level, and then it'll obviously calculate the level based upon that, but I don't really view that as really suggesting a code any longer. Versus I think in the past, when you put in all the data, there was so much more of a focus on points. That as you put in the various things, it sort of helps kind of lead you towards a particular E&M. But I think on a go-forward basis, we won't really have that.
Armando, does your EMR, does it suggest a code for the providers to go on?
It does. It does suggest a code, and a couple of times, if I do put in differential diagnosis for a routine test, it actually gives me a higher code, and I end up down coding it for one. But for the most part, it tends to down code, and I can adjust it. But I spend a lot more time adding differential diagnosis and more on the complexity of the case.
Okay.
So.
And Nathan, your EMR is suggesting code, you said, right?
Yes. Mm-hmm. Yeah, we use Xperity. I don't know what you guys use, but yeah, it does.
Okay. Does anybody use professional billers to go over visit notes and sort of confirm codes? You do it, Nathan. You do.
Yep. We have a whole slew of in-house billing team, and yes, they review those before they send them out. Make sure everything looks as good as it can, in hopes to not get denials or get pushback. They'll reach out to the providers sometimes to even say, hey, can you clarify on this? And so we'll see that. But yeah, they are going through those and trying to make sure all the T's are crossed and the I's dotted, so it looks good before it gets submitted.
Quick question.
Do you use a professional billing company, or do you do it in-house? Are you specifically looking at the recent changes to the E&M code structure when those bills go out?
Oh, sorry. So it's in-house. I just consider them a professional billing company because that's their profession, and
Okay.
they've worked for different billing companies. I guess we're just and we've used that before where we've outsourced it, but I guess we're at a size where we can have our own full-time team. But that's their profession. That's all they do.
Right. Okay, Claudia, how about you? I'm
sorry, go ahead.
Yeah, how's your billing handled, and have you been specifically looking at these revised E&M codes and things like that when the billers are looking at the charts?
We're kind of still in this learning curve because we just brought our billing in-house at the beginning of the year. So this first quarter has all been spent on developing those teams. And I hate to admit it, but we probably don't have as much oversight internally as we hope to, the level we hope to achieve soon. So again, that's just kind of a project that's ongoing. Previous to the beginning of the year, we outsourced our billing actually through Xperity's billing department. And so we did appreciate their oversight on coding issues and things like that, but we're kind of on our own now. So we're figuring it out as we go.
Okay, all right. I have another question that was submitted about work comp COVID infections. And the question is, have your clinics seen work comp reportable COVID infections? And if so, what has your experience been with them? Armando, have you seen?
Go ahead and restate the question. I didn't quite hear it.
Have you been treating any COVID infections through as a work comp case? At work or whatever, and if so, what's it been like? What's your experience been with those?
We do see work comp, but we haven't seen those yet. Most of those tend to be long haulers. If there's patients that that have issues, and I haven't seen them through work comp, but I would certainly ask that my staff on that, 'cause I don't really jump into that scenario on that.
Okay, Nathan, has your group seen any work comp COVID cases?
Yes, we have, but it's really been a good experience, I guess, in the sense the employers been okay and understanding, and then the employees, just follow our guidelines, which is, whatever it is, 10 days of isolation out of work, for those 10 days, and then trying to get people tested, that worked with them. And so, and these are kind of previous accounts that we've had before, like a grocery store or a kind of factory type business where a lot of they're considered essential workers. They work close contact with each other, and then people, got infected, and then it all went through work comp. But we were able to take care of them, and it wasn't a bad experience. I'm interested though in the whole COVID long hauler thing, and I think this is something that's we're going to be urgent care. We're going to be ripe for us to be in a position to help patients with what they call long COVID, or these long haulers with symptoms, and especially as it may relate to their work environment and what that's going to mean, and how it's going to go through work comp. So I'm really interested to see how that'll play out. But I do think that's, like Armando said, I think that's something that's coming down the pipelines.
Yeah, we've had I know about probably half a dozen cases. I don't know if they qualify as long haulers yet, but they would definitely qualify to be called prolonged symptom COVID cases. 3-4 weeks duration. And it's been a little tricky trying to determine when they're, I guess, safe to go back to work. And there's a safe from a medical point of view, just from what the CDC says, but there's also, so you send someone back to an employer and they're still coughing, the employer basically, doesn't let them come back. So we've been dealing with that a little bit. Tiffany, have you been dealing with any work comp COVID stuff? Besides, I guess, more of a long term I'm looking for. I'm asking about instead of just a standard kind of take them off work kind of work comp.
Yeah, I think we've had one person that I would consider a long hauler, and she was actually a mid-level working for another clinic. And we've had similar problems. Well, I guess the problem we've had is it's really hard to objectively define their symptoms when you're getting into 4 to 6 months of fatigue, shortness of breath, that type of thing. So we've just kind of hung on with her, and she's been off work for a very long time. So I don't know what's going to happen with that, but it hasn't been the easiest thing to kind of follow, especially I think she's like in her 40s. So yeah, one so far. The other ones are all just your standard 10 days back to work, acute illness that resolves.
Okay. And our final panelist, Dr. Radner, has joined us. Thanks, Alan. Appreciate you showing up. I know you've got another meeting probably, I think, scheduled right at the same time. So I really appreciate your joining us here. And Alan had a question. My first question for you is, can you give us just a little roundup of the status of the COVID infections and hospitalizations in Monterey County right now?
Sure, Scott. In Monterey County, we are, we've definitely, like most of California, seen a significant decline in the number of hospitalizations due to COVID. We're all running about 1 or 2 inpatients, and fortunately, so far they're doing pretty well. Our understanding is there's been a slight uptick in the total number in the county, but they're been predominantly in younger age groups, as you might expect. It's been kind of teenagers, late teens, early 20s. And fortunately, they haven't been as ill. So in Monterey County, on the admission side, the hospital side, we've definitely seen a significant decline in the number of inpatient COVID admissions and the volumes in our emergency departments as well.
What variants are floating around in Monterey County right now?
So, I mean, I don't know that it's been generally made public, but there is this quote unquote Northern California variant, the B1429/1427 variant. And this actually probably been the predominant variant circulating in Monterey County and in much of Northern California since November, December. We're now doing a whole genome sequencing at the health department, and it's about at least 75%. And again, the data is not really out there, but this seems to be probably as infectious, if not more infectious, than the UK B117. So everybody is kind of freaked out about that variant coming to Northern California, but many of us believe that the California variant is just as infectious. We're told that everything has been found in Northern California. In Santa Clara County, they've had P1, they've had the South African variant. I mean, there's had these combined variants now. So everything's here. We haven't isolated that in Monterey County, but I know they've isolated most of these variants in the surrounding counties, and I'm sure it's here. We just haven't found it. I'm not entirely convinced that if we had a war between the B117 and the B1427/29, that the Northern California variant wouldn't win, but we'll have to see how that plays out.
You know, with the opening of businesses here in Monterey and across the state, of course, in the country, you know, everyone I think is really kind of relieved that there's a lot more to do and you can go do things and so forth. Do you have any concern about a sort of fourth wave or a next wave of COVID infections because of the opening up of the economy?
Yeah, I mean, I think that, you know, look at Michigan right now. I mean, they have no ICU beds. It sounds like Michigan is as bad as we were in December, January. Buffalo, parts of New York, obviously, New Jersey, parts of Illinois, parts of Florida. Canada is apparently in Ontario, they don't have ICU beds. You know, my statement forever had been, this isn't going to magically disappear. This is going to disappear when there's immunity. And I don't know exactly what that number is, but and the only way we're going to get immunity is through either infections or vaccinations. So what our hope is that, you know, these places we're talking about, like in Canada, you know, it's single digit vaccination. In Monterey County, it's like 40% of the eligible population. So our, you know, it's this race between immunity through vaccination and prior infection versus all these issues, whether it's variant strains, whether it's opening up the economy, whether it's in Monterey County and much of Northern California, it's seasonal ag workers coming from other places where there's a lot of infection. We're just gonna have to see how it plays out. I mean, I think we're all very concerned that there will be further surges, but we're doing a really good job getting people vaccinated, and assuming there's not another real ugly variant that the vaccine doesn't work on, we're hopeful that we'll mitigate it, if not prevent it. It's, you know, it's hard to predict the future. I mean, there's people who predicted, I wrote an editorial in papers here last March when we were opening it up and everybody's like, oh, we're opening things up. And I'm like, there's no reason to believe this isn't coming back. And it came back in the summer, and compared to the summer, the, you know, November, December, January surge was very ugly. So, so anybody that's predicting the future is a lot braver than I am, but I'm much more optimistic than I had been in the past.
Yeah, you know, one of the things I've noticed is there doesn't seem to be a lot of correlation between the weather and the surges of this vaccine. What accounts for that? Why isn't it acting like the flu in a sense? In that sense, it's just because the mask wearing is shifting the way it works or spreads.
Yeah, I think the hope had been, or the thought had been, that this was going to behave like influenza and many respiratory viral pathogens, including previous coronaviruses that seemed to be in cooler weather, it was spread more. And maybe that was schools and closer contacts and humidity issues. But when you look around the world right now, it's just really hard to correlate these surges with weather. I mean, if you look at Manaus, Brazil, and you look at Mumbai, and you look at Ontario, Canada, you know, it's hard to, you know, I think hopefully down the line in many years, somebody's going to be able to explain some of this. But right now, I think we can't count on the weather in any way, would be my bottom line.
Before you came on, Armando had mentioned a new treatment modality using SSRIs.
Yeah.
What's that about?
Yeah, fluvoxamine is an SSRI that's been looked at. I mean, literally, it's been in that I've seen data. It's a few hundred patients, and it looks like the risk of progression in people given this. I mean, the biggest study actually was in a bunch of people. There was an outbreak in one of the racetracks in Berkeley, actually, or outside of, and it's impossible to recommend it. There's some theoretical reasons that it may work as an anti-inflammatory or immunomodulator, but I can tell you the Infectious Disease Society of America, World Health Organization, nobody is recommending it on the incredibly small number of people that have been studied to date.
Okay.
Yeah.
When you a lot of the stuff in the paper right now about, and Nathan just mentioned it, the COVID long hauler, I guess, syndrome, or what's your feelings about that?
Yeah, I think it's really going to be a challenge for all of us. I mean, we've talked at the hospital I'm mainly work at, St. Memorial, about putting together a long, quote unquote, long hauler clinic. And one of the huge problems is this is a really heterogeneous group right now. So it's the spectrum from people that have horrible, interstitial lung disease, pulmonary fibrosis, from being on ventilators, to loss of smell or depression, behavioral health issues. And it's really hard to, have an answer to that. There was just some paper that came out that said a third of people within 6 months of having COVID that were symptomatic end up with either behavioral health issues, depression, anxiety, brain fog, neurologic complaints. It's just, again, I have no idea how to counsel people and what to do. And we didn't know even how to structure a clinic. I mean, as I said, there's people who need to see pulmonologists for severe pulmonary issues. There's people who need to follow up because of documented strokes or neurologic deficits. And there's a huge group that has depression, anxiety, brain fog. It's just going to be a real challenge. And you guys are going to see, or you already are seeing a lot of those people. I mean, and I wish I had a more robust answer. I just think we're all going to have to learn about that and deal with that.
Do you feel the current vaccines are effective against all these variants that we're hearing about?
Yeah, I mean, the real good news is that if you use as your endpoint death, hospitalization, really severe illness, all of the vaccines seem to be equally effective throughout the world in all the studies. And so far, we just have not seen, people who were vaccinated end up dying, for instance, of COVID. We've had a couple people in Monterey County who were clearly vaccinated many months out who developed COVID. And there was one nurse at our institution, her husband was not vaccinated. He had pretty severe COVID. She was exposed. She got a little bit of sore throat. We tested her. She was positive. And that's what we've seen so far is the people who had adequate vaccination that were diagnosed with COVID have very mild illness. So I think as of right now, we're all, again, really optimistic that the vaccines are very effective in preventing severe life-threatening disease and death in people who are vaccinated. Are there going to be more variants where we can't say that with certainty? I just don't know. But right now, I think all the vaccines are equally effective at that. Whether there's some differences in who gets mild illness or moderate illness, who've been vaccinated, I'm not even sure we can clarify that at the moment because the trials weren't head-to-head. They were, trials, and the J&J trial was at a very different time in a very different place than the original Pfizer trials and the Moderna trials.
Quick question, Alan, is that for the vaccines, is that the same data for, I've heard that for the South African virus, the 1351 and the P1 in Brazil have had not as great a response to the current vaccines, but I haven't heard any details. Is that?
Yeah, again, the data I've seen, you can look at, there's a woman at UCSF, Monica Gandhi, who likes to, she's kind of the major voice of this. And she has this really cool chart that I use when I give presentations. And, the argument is still, they're not, for a lot of reasons, the trials aren't apples to apples, but when you do look at death and hospitalizations, they look very equivalent, everything, even the groups like Novavax, all of the trials look very, very similar. The best discussion I've heard of this was Bob Wachter at UCSF says, he goes, the way to compare these is like, you have somebody that goes and plays a round of golf on a beautiful day and gets a score that's, really nice. And that's like the Moderna Pfizer trials. And you look at like the J&J trials that were done and the AstraZeneca trials that were done, he goes, it's like somebody out and going playing golf in a hailstorm. Their scores aren't as good, but it's really hard to compare, what would Pfizer look like and Moderna look like right now in Africa, where there's a much higher degree of disease with strains that probably have higher viral loads, probably have a higher lethality, have variations. So I still have seen no data that with respect to severe outcomes, that there's any difference in any of the vaccines right now. And that's about the strongest statement I can say. And that's really what we're trying to do, right? Not have people in the hospital and die.
What's
Thank you.
going on with the AstraZeneca vaccine, Alan, from your point of view? I mean, I know
Yeah,
it's a question, but
a whole bunch of methodologic problems with the AstraZeneca trials, but the bottom line is they're seeing thrombotic complications. So they've had young people with not insignificant things like cavernous sinus thrombosis, et cetera. And the question is, you've always got to try to understand the background noise. When I was talking to people about this, I said, if I was to give 1 million people porridge today in the United States, there's going to be X number of people who die because X number of that million are always going to die. And there's going to be somebody that's probably even going to die because they're going to choke on their porridge. And there's probably going to be somebody that's going to have anaphylaxis, but most of the complications are background noise. And I think that's what we're trying to sort out with the AstraZeneca vaccine. I mean, I think if we didn't have such phenomenal data, safety and efficacy with the mRNA vaccines, I think we'd still say these are phenomenal, right? They're still very effective. And even if we were saying the FDA was going to approve a vaccine with 50% efficacy. So if we were looking at AstraZeneca, that was the only thing out there, and we knew, the numbers of deaths we were seeing with baseline COVID, we would say, all right, a few people are going to die from thrombotic events, but these vaccines are incredibly effective, and the overwhelming majority of people aren't going to have these, and they're really safe vaccines. But given that we have what seem to be really safe alternatives, there's this dial back. I mean, one of the problems with that, though, is the AstraZeneca vaccine is a relatively easy vaccine to manufacture, and it's really easy to distribute. It doesn't require the same storage issues. And a lot of people were hoping that this was going to be the major vaccine for much of the world, including continental Europe. And pulling it off the market is just really a huge setback. I mean, I think it's less than 5% of the world has been vaccinated. So we still have a huge problem. And there's, that's where are these variants going to spit out from? Yep. They're going to spit out from the rest of the world. It's really depressing.
Anybody else on the panel have any last question here? We have about another minute or two with Dr. Radner. All right.
With all of these variants that have popped up related to this, is there any indications at this point of, are we going to need to have an annual vaccine like the flu shot, or the fact that so far the same vaccine has been able to address quite a few different variants? Is there any indications or any conclusions we can draw? Is it still too early to tell?
Yeah, I think it's too early. I mean, I think there's two issues, right? Why would we need annual shots or boosters? I mean, one is if our immunity wanes, and antibody titers will come down with time, although there's some really optimistic evidence that T memory and B memory cells, which are pretty critical. A lot of immunologists would argue that's really the most important part of these vaccines long term. They seem to be preserved. So, one reason we might need a booster is if our immunity waned, and we just don't know. We don't have the time. We know Pfizer just came out with this data, and Moderna came out with data saying it works at 6 months, which was, I think, grossly misinterpreted. I've had patients say, well, I don't want a vaccine that only works 6 months. And I'm like, well, it got FDA approval when they were only looking at it for 2 months. And now they're saying, we looked at it for 6 months and it's holding up. And some people are interpreting it as only 6 months. So, I think there's some hope that the vaccine will last, or your immunity will last a long time. The second issue is just what you mentioned. We don't give annual flu shots necessarily because your antibody titers wane. It's because the variants change such that the epitopes or the targets just aren't consistent, and we need antibodies to new targets. And, I think there's a lot of concern about that. But, we'll all have to see. Your guess is as good as mine. Yeah.
Thanks.
Thank you.
Yeah.
Thanks to everybody on the panel for joining today. We'll, have another event in May, and we will send out an invite for that. And I'll see you all then. Okay.
Thank you, Scott.
Take care of yourself. Thanks for joining.
Thanks, everybody.